Thank you. You can post questions in the chat. We will try to answer them either via the chat or afterwards if they're really important. We will, if there's one or two very, very important ones, we will try to squeeze that in, but we would really like to stop at 6 sharp. Thank you. Sarah, on to you. Thank you.
Thank you, Pete. I will start with sharing my screen.
Voilà.
So if all goes well, you should see it now. So indeed, thank you. I'm Sarah Nuijs. I'm project manager at EORTC, and I'm responsible for the E2Radiate platform from a project management perspective. And I'm going to present you one of the cohorts, which is OligoCare. First, I would like to frame the E2Radiate again. So we have a collaboration program between EORTC and ESTRO. Under this collaboration program, we have E2Radiate platform and the Oligo-care clinical trial, both are open for enrollment. And within the E2Radiate platform, we have 2 cohorts, OligoCare and ReCare. And very soon we will also open TWIX. It's a trial within cohort design under the Oligo-care cohort. And that one is called Sprint. We have a website on E2Radiate, which is shown on the left. The objectives and aims of this platform are to make a collaborative scientific framework to understand, foster, and position radiation oncology in Europe. It also creates a unique clinical research infrastructure to generate robust data and provide evidence on the role of radiation oncology for the treatment of cancer. It provides an umbrella to cover the entire spectrum of research-related radiation oncology into therapeutic strategies and therefore practice, and it offers pan-European solid models attractive to partners, and it creates a significant and critical data mass which can be influential at all levels of clinical research, technology development, regulations, and healthcare systems. This slide shows you an overall enrollment into the platform since 2019. It goes very steady. So you see in the first quarter of 2024, we already enrolled 72 patients. Here you see the registration per country. Top recruiter is Italy, and then Belgium and Swiss on the 3rd place, or Switzerland on the 3rd place. Now I'm going to dive a little bit deeper into the OligoCare cohort itself. So what is it? It's a pragmatic observational cohort study to evaluate the radical radiotherapy for oligomet cancer patients. The objectives are to identify patient tumor diagnostic and treatment characteristics impacting the overall survival. It evaluates patterns of care and patterns of outcome. The primary diseases are lung, breast, prostate, and colorectal cancer, and the cohort coordinators are Matthias Guckenberger and Piet Ast. Then why would an investigator participate to E2Radiate? You will have the opportunity to be represented in publications. You may request benchmarking reports that rank your institution against other institutes. You can have a role in helping making a clinical decision. Here, this one is highlighted because you also have access to data to generate research projects, and this data is all data from the cohort to which you are actively participating, and you can do networking. You also have a link to why and how to participate, where all these items are more elaborated on the website. Then we are very welcoming new ideas for other cohorts, research ideas with the data of the existing cohorts, and other trial within cohort research questions like we have now, or we will soon have the sprint. If you have an idea, please contact the cohort coordinators or go to the E2Radiate website and complete the basic information requested in the form. And your idea will be submitted to the E2Radiate steering committee and to be evaluated. Then a little more on the enrollment of OligoCare itself. So here you see the enrollment per month, and I'm very happy to inform you that a couple of days ago we reached the milestone of 2,500 patients enrolled in OligoCare. So that's very impressive. Yeah, a little bit more details on the top recruiting sites. We have Italy here, Switzerland, Netherlands, Austria, Belgium, and Slovenia. So thank you, and they're doing very well. I also want to share some info on the database that we have in-house, on the data collected. So here you see an overview of the completion status. You see the different forms and the number of forms missing. The overall status of missing data is quite low. It's only 3.7%. And it even decreased since the last missing data communication. So this shows that all the sites participating to this cohort are very responsive. And in total, we have now 1,600 open queries in a database, but spread over 2,500 patients. So also this is very good. Then we have a database lock upcoming at the end of March. This will be a lock on all data of the first 2,200 registered patients. And the data of this lock will be used for the analysis of health-related quality of life data, which will be showed during ESTRO 2024. And it also serves as data for future data sharing requests. And I give now the word to Matthias for some updates on the research done within the OligoCare. Stop.
Hi, everyone. Can you see my screen?
Yes.
Excellent. So good afternoon, everyone, and warmly welcome to the EORTC and ESTRO OligoCare Symposium. One major difference between the OligoCare cohort and a regular trial is that we constantly try to address questions which are relevant for all of us who have implemented SBRT for oligometastatic disease in our routine daily clinical practice, because that's what we are collecting, what we are practicing in our day-to-day routine. And there we want to generate evidence, we want to generate some benchmarking opportunities for all of us. What is happening in our neighboring institutions? How could we kind of individualize the treatment in these patients being treated for oligometastatic disease? We have run 3 analyses so far, and I just want to give you a glimpse inside what we have found so far and what we've learned. Also, at this point of time, many thanks to ESTRO and EORTC for supporting this project. Thanks in particular to all participating centers, all colleagues and patients who are dearly contributing their time and their energy to this international collaboration. I would call it a community effort. The first question we addressed is a very one based on radiation oncology's interest. It's about what dose of radiation should we use. This is one earlier publication I've done when I was still being young, where I evaluated dose-response relationship for local tumor control if oligometastatic lesions in the lung are being treated. And what we found is that there was quite some variation in the tumor control probability between, for example, colorectal disease, which required a higher dose to achieve local control, as, for example, breast cancer. But this was based on, as you can see, very small patient numbers. So we don't know whether this holds true or this was just based on exactly small numbers. We also know the dose is related to toxicity, so the optimal dose and fractionation for SBRT in oligometastatic disease still remains unknown until today. So one early analysis was based on the first 1,000 patients, 1,100 being the data log and 1,000 being analyzed. What is actually the dose being delivered in our real-world clinical practice? And if doses were converted into BED doses, the median dose to all metastatic lesions being treated was lower than this threshold of a 100 gray, which is kind of a bit the magic number to achieve 90 or 95% local tumor control probability. You can also see that by using a generic alpha beta of 10, doses were higher for colorectal and lung cancer as compared to breast and prostate. This doesn't really reflect our clinical experience, because if I look into my practice and if I look into the literature, the local tumor control in breast cancer and prostate cancer and oligometastatic disease is excellent. And that is being reflected if doses were being converted using disease-specific alpha-beta ratios. Here, doses were being higher for breast cancer and prostate cancer. So indicating that using disease-specific alpha-beta values, which we've established in the primary tumor, not in oligometastatic disease, might also hold true when treating metastasis. The second factor which was associated with dose being delivered was, as obviously, the location of metastasis. We adapt our treatment based on the maybe overall survival, based on the disease, but also about the safety. And in particular, for example, in pancreatic location or in long bones, doses are lower as compared to, for example, lung and liver. But keep in mind that there's quite some interconnection between the location and the primary disease. Next steps are obvious: the analysis of dose versus toxicity and efficacy. The next question we addressed again in an interim analysis, now being based on about 1,000 patients, 1,600, was the safety aspect. This is a systematic review published a while ago looking into the safety of SBRT. And this was being based on the trials you can see here, mostly small trials with less than 100 patients being conducted in highly specialized centers. Toxicity was very low, below 2%, grade 3 to 5. The question is, does it also represent our real-world practice? Is it also safe in a real-world environment? So that's what we addressed in this interim analysis. The first 1,600 patients, of which about 1,500 made it into the analysis. These are the patient characteristics. I will not go into the details, but the majority of patients are prostate cancer patients having a good performance status, majority having de novo oligometastatic disease except colorectal. Most of them, I guess, have been treated with surgery before. Most of them do not give systemic therapy concurrently, despite 40% roughly do, and the age is at the age of 60 to 70. The dose is similar to what we reported before in the first 1,000 patients, so it didn't change, about 75 gray BED based on an alpha-beta ratio of 10, and that was delivered in a median of 5 fractions. This is the toxicity being observed, very encouraging. This is prospective data we have been collecting here. Toxicity within 6 months of 0.5%, 8 events of grade 3 or higher toxicity. And you can see the details here. There's not a single toxicity which is being observed more than once. And there were only 2 toxic deaths, 1 radiation-induced pneumonitis and 1 cerebral bleeding. So again, very encouraging that the doses we are applying, we don't know about the efficacy, but at least in short-term safety, well, that has been shown. The last analysis which has been done and published is on quality of life. Again, on short-term quality of life within 6 months. 655 patients were analyzed being treated for oligometastatic prostate cancer. And that is something where we were a bit concerned. Only 233 were having a quality of life assessment at baseline, and only 132 patients did have quality of life at baseline and at follow-up. So this might be something we can take back to our home institutions and improve the recruitment, not only in numbers, but also in kind of data quality, data completeness for quality of life. You can see here the follow-up, the changes in quality of life in the respective domain. In gray, where there was no change in quality of life. In blue, where there was an improvement in quality of life by a minimum of 10-point scale. And in red, where there was a deterioration. On average, it was stable. There were 2 domains where we saw slightly increased a burden, so decreased quality of life, fatigue, and pain. We looked at, in particular, this is prostate cancer patients, whether there was a confounding factor of concomitant systemic therapy, ADT. It was not being observed. So I want to come to a summary already. Thanks a lot. We have seen a successful implementation of OligoCare to collect real-world data of patients being treated with SBRT for oligometastatic disease. The participation of you all, of us all as a community, is above all expectations we have. The data quality and completeness is strong, except some domains where we see some room for improvement. And we try to push continuous analysis for benchmarking. And as Peter has already done, we would like to invite you all to submit your ideas, your innovation, your creativity, to ask interesting questions based on these 2,500 patients which have been enrolled. So thank you very much for this effort so far, and thank you very much for staying with us on this journey. And with that, I would like to hand over to Pete again.
Thank you, Matthias, for this helicopter overview of what we have achieved now. I do want to highlight that at upcoming conferences, we will keep on updating this database with newer data. So keep tuned for that. I see that we are now over 200 participants, which is amazing. Thank you again for being here. I would like now to pass on to Daniela Greto, who actually analyzed the first data together with EORTC team on quality of life, but for the entire cohort, so not solely focused on prostate. So please, Daniela, take over and show us what you found.
Ready, Giulio? Good afternoon. Could you see my slides?
Yes.
Mm-hmm. Okay, thank you. It is a pleasure for me to present on behalf of the Quality of Life OligoCare core team the early result of quality of life after stereotactic body radiotherapy for oligometastatic disease. These are the results of the OligoCare subcohort. As we all know, stereotactic body radiotherapy has an important role in the multimodality treatment of oligometastatic disease, and it is well known and affirmed by the results of phase 2 trials and international clinical guidelines. In the last years, life expectancy in oligometastatic patients is increased, and so the maintenance of a good health-related quality of life is too important. It has to be an important objective in the management of this patient group. So it is important to understand the impact of stereotactic body radiotherapy on health-related quality of life to improve the patient-centered care. We know that OligoCare cohort has a primary endpoint of overall survival, and the analysis of quality of life is a secondary endpoint. And so, in our sub-analysis, we include the patients who underwent the stereotactic body radiotherapy and with quality of life data among the first 1,600 registered patients. The clinical cutoff date of 28th February 2023 was determined on the last date of radiotherapy for the patients plus 6 months. In this flowchart, we can see the accrual. First of all, 1,600 patients were registered for OligoCare. Of these, 1,500 received stereotactic body radiotherapy. And of these, 530 patients had a baseline data on quality of life. Of these patients, 269 had at least a follow-up of 6 months in quality of life data. This is the geographical distribution of the enrollment. And the prompts were evaluated using the EORTC quality of life questionnaires cohort 30. As we know, it consists of 5 functional scales: physical, role, cognitive, emotional, and social functioning, 3 symptom scales: fatigue, pain, nausea, and vomiting, 1 global quality of life scale, and 6 items. The scores range between 0 and 100. The symptom scales had higher scores that translate in more severe symptoms. On the other hand, functional scales with higher scores, we have a better functioning. To assess the change in quality of life score, we use a 10-point difference threshold from the baseline. It means that the deterioration was defined as a loss of more than 10 points from the baseline, and an improvement was a gain in 10 points from baseline in the quality of life data. Our primary objectives were global quality of life at baseline in all patients receiving stereotactic body radiotherapy for oligometastatic disease and bi-primary disease, and also the analysis of global quality of life within 6 months after starting stereotactic body radiotherapy. Exploratory objectives were baseline functional domains, the analysis of the subdomains, and the same analysis at 6 months after starting stereotactic body radiotherapy. Also, we analyzed the difference from baseline to first follow-up assessment within 6 months after starting stereotactic body radiotherapy in global quality of life and also subdomains, by evaluating the change of the quality of life scores, always with a 10-point scale. Also, we analyzed the relationship between global quality of life at baseline and baseline clinical disease and treatment characteristics, and the same relation at 6 months after stereotactic body radiotherapy. In total, we have 530 patients with a baseline quality of life questionnaire. Most of these were prostate cancer, and followed by non-small cell lung cancer, breast cancer, and colorectal cancer. A total of 269 patients had both baseline and a follow-up, as just said, of at least 6 months in the follow-up. The reasons for exclusion were no follow-up assessment of the quality of life, or the first follow-up assessment that was after 6 months from the beginning of stereotactic body radiotherapy. These are the patients' characteristics. About 71% of patients were male, with a median age of 69, a range between 28 and 91. The WHO performance status was equal or less than 1 in most part of patients, about 19%, and the 50% of patients had comorbidities. Looking at the metastasis at baseline, so the most part of patients had 1 metastasis, but the range was 1 to 8. The number of treated lesions was, for the most part of patients, 1 in about 73.4%. But surely only a few patients had a treatment of more than 4 lesions. It is about 6 patients. Looking at the sites involved, the most part of patients had a location in non-vertebral bones, followed by lung, and after spine. Sorry for the busy table, but it is just to outline the prior treatments for the patient. The most part of patients underwent surgery of the primary tumor, and a half of patients received radiotherapy for the primary disease at diagnosis. About 60% of patients had any systemic treatment given before. But looking at the concomitant systemic treatment, we can see that about 40% of patients received stereotactic body radiotherapy concomitant to systemic treatment. In particular, in most cases, we had hormonal therapy followed by chemotherapy, target therapy, and after at least immunotherapy. Looking at the results of the global quality of life at baseline, we had a mean score of 72 with a standard deviation of 19. There were some difference across the groups, just how to Matthias just said before in the specific analysis of prostate cancer. We can see that prostate cancer patients had a median of 78, that was higher compared to non-small cell lung cancer, 65, breast cancer, 68, and 71 in colorectal cancer. The mean global health-related quality of life at 6 months was stable respect to the baseline, and we had a mean value of 72 with a standard deviation of 19. In particular, if we look at the If we look at the change in the global health-related quality of life, I just said it was calculated with a 10-point difference from the baseline. We saw that about 22% of patients had at the
You muted yourself, maybe?
Yeah, Daniela, you seem muted. Probably by accident.
Yeah.
You're back.
Okay.
Thank you.
Looking at the change in the quality of life, in the global quality of life, calculated as a 10-point difference threshold, we can see that about 22% of patients had a deterioration of the global quality of life, and a 15.3% had an improvement. In particular, 21.1%, 34%, and 25%, and 17.4% of non-small cell lung cancer, breast cancer, colorectal cancer, prostate cancer, respectively, had a deterioration. An improvement was obtained in 25, 17, 15.6, and 10.6% in non-small breast, colorectal, and prostate cancer, respectively. When we look at the characteristics, at the association of patients' baseline characteristics, baseline global quality of life, a multilinear regression, it was evident that the type of primary disease correlated with a global health quality of life. In particular, patients with prostate cancer had a baseline global quality of life higher than non-small breast and colorectal cancer. And also, WHO performance status correlated with the baseline global health. In particular, patients with poorer performance status had a poorer baseline global health. Looking at the change in global health from the baseline to the first follow-up within 6 months from the start of stereotactic body radiotherapy, no patient's treatment characteristic correlated with global health. In particular, also there was no correlation in the number of treated lesions and also if patients received or not systemic treatment. So we can conclude that the collection of quality of life data is feasible in a prospective registry, that a follow-up of 6 months global health-related quality of life remains stable following metastasis-directed stereotactic body radiotherapy, in particular in oligometastatic breast, colorectal cancer, and prostate cancer, but absolutely further analysis are needed to better understand our preliminary results. In fact, further analysis are ongoing, subdomains, exploratory objective, updated quality of life will be presented at ESTRO 2024 of the eligible patients among the first 2,200 registered patients. And a special thanks to all the quality of life OligoCare core team, and a special thanks to Professor Matthias and Pete, and also to Felix Opong for the statistical report. Thank you.
Thank you so much, Daniela, for this beautiful overview. I think these are the first results of quality of life of the entire group. Indeed, one of the questions is this deterioration due to SBRT or disease progression? I think it will mostly be due to disease progression or concomitant systemic therapies that are being given. But I think these are things we further have to delve into. Next up, specifically, will be another Italian contribution. And as you can see, not only in the OligoCare in general, the Italians are very good recruiters, but they're also now recruiting very well and producing very nice data in randomized trials. So I think that's a beautiful example that both can actually work together. Thank you, Giulio. So I would like to pass on to Dr. Francolini, who will give us an update on the Arto trial, which is one of the newest additions to the randomized trials we have in prostate cancer. We have now around 5 randomized phase 2 trials, with this one being in a setting which we hadn't seen before, being the MCRPC. Without further ado, go ahead, Giulio.
Thank you for the presentation. I will now share my slides. Can you see my screen now?
Perfect.
Okay. Sorry. So thank you for the presentation and for the invitation to discuss the results from Arto trial, a trial that was designed to test the benefit of SBRT addition to abiraterone acetate in first-line setting of metastatic castrate-resistant prostate cancer patients. The background of this trial is based on the fact that androgen receptor target agents represent one of the main treatment options for metastatic castrate-resistant status. Nonetheless, SBRT has been shown to significantly prolong ADT-free survival and progression-free survival in oligometastatic hormone-sensitive disease. However, evidence in the oligometastatic castrate-resistant status was lacking. With this in mind, we designed a randomized phase 2 trial enrolling metastatic castrate-resistant prostate cancer patients with no more than 3 lesions, without any visceral extension of disease, and without any previous therapy for castration-resistant status in metastatic scenario. These patients were randomized to receive either SBRT on all metastatic sites of disease. Primary endpoint of the trial was biochemical response, defined as a PSA decrease higher than 50% from baseline within 6 months from treatment start, and secondary endpoint of the trial were complete biochemical response, defined as PSA at 6 months lower than 0.2 nanogram milliliter, progression-free survival, and overall survival. Quality of life has been measured at each time point, but at this current status, these are unpublished data. Abiraterone acetate was administered with a standard dose schedule consisting in 1000 mg once daily plus prednisone 50 mg orally twice daily, and all dose and fractionation of SBRT were allowed, provided that treatment was administered to all sites of disease with a biological effective dose of at least 100 gray. In order to evaluate homogeneously PSA response in all patients enrolled in the treatment arm, all patients undergoing SBRT were treated at 30 days from the date of first abiraterone acetate administration. This is the statistical plan. We assume that a proportion of patients achieving biochemical response was 62% in the control arm based on data from the pivotal trial cohort 302. With this in mind, we knew that 156 patients were required to show an improvement of 20% in the experimental versus control arm. As you see from the slide, we started our accrual on 1st January 2019 and ended the enrollment on August 2022. Data analysis was performed in March 2023 when all patients reached a minimum follow-up of 6 months after SBRT treatment. Results show that in terms of baseline population features, these features were well balanced across arms of treatment in terms of age, ISUP score, number of lesions lower or higher than 1, site of metastasis such as nodal only or bone disease, and type of baseline imaging, with the vast majority of patients undergoing colon PET-CT as a baseline imaging. In terms of biochemical response, it was the primary endpoint of the trial. Results show that there was a significant improvement in the experimental versus control arm, with an odds ratio for biochemical response of 5.34 and an odds ratio for complete biochemical response of 4.22 in the experimental versus control arm. Both reached statistically significant results. In terms of subgroup, at univariate analysis, only treatment and baseline PSA were significantly associated with rate of biochemical response. However, at multivariate analysis, only treatment persisted as a predictive factor for biochemical response in the experimental arm. In terms of complete biochemical response, at univariate analysis, only treatment arm and staging methods, PSMA versus every other staging method, had a significant impact of complete biochemical response. We thought that these data were really interesting, suggesting that patients treated extensively on all PSMA-avid sites of disease had a higher ratio of biochemical response to SBRT. However, at multivariate analysis, only treatment arm persisted as an independent predictive factor of complete biochemical response. These are the results in terms of progression-free survival intended as a composite endpoint, including both PSA rise, radiological appearance of new metastatic sites, start of following treatment, or death, whichever occurred first. After a median follow-up of 25 months, we registered 75 progression events, and median progression-free survival was not reached versus 17 months in the experimental versus control arm, with an hazard ratio for progression of 0.35 in favor of the experimental arm. Of note, patients enrolled in the control arm had a progression-free survival comparable with data from the experimental arm of the cohort 302 trial enrolling patients treated with abiraterone acetate versus placebo, suggesting that no bias selection was included in the cohort enrolled in the Arto trial. In terms of biochemical progression-free survival, biochemical progression-free survival was reported as the third progression-free survival event in 36 patients, well balanced across treatment arm, and median biochemical progression-free survival was not reached versus 36 months. Hazard ratio of 0.3 was confirmed in favor of the experimental arm. Going to most clinically relevant endpoint, such as appearance of new metastatic sites, median radiological progression-free survival confirmed to 0.39 in the experimental arm in favor of the experimental arm. Again, in terms of freedom from following treatment, defined as second-line systemic therapy, SBRT for oligoprogressive disease, or best supportive care for poor clinical condition, which was provided in 40, 22, and 12 patients respectively, median time between abiraterone start and subsequent treatment approach was almost doubled in the experimental arm, with an hazard ratio of 0.37 in favor of the experimental arm. Results in terms of overall survival are not yet mature. After 25 months, we registered 24 events, and median overall survival was not reached in both arms of treatment. At the current status, that is a non-statistically significant trend in favor of the experimental arm. However, it should be noted that in cohort 302 trial, in order to get a benefit in terms of overall survival, authors should have waited for at least 50 months of median follow-up. Thus, these results are currently not yet mature. These are the safety data. As you see from the table, most toxicity were mild and mainly related to systemic treatment. In terms of grade higher than 2 adverse events, only 13 versus 8 events were recorded in the control versus experimental arm without any statistical difference in the two arms of treatment. And this was valid as well for special events of particular interest, such as fracture, hematuria, or gastrointestinal disorders. In terms of future developments for the concept of SBRT addition to androgen receptor target agents, 20 Italian centers are currently enrolling actively within Persian trial, a second trial enrolling oligometastatic hormone-sensitive prostate cancer patient with no more than 5 lesions amenable with SBRT and treated with either apalutamide plus androgen deprivation therapy or the same systemic therapy plus SBRT on all metastatic sites of disease. Primary endpoint of the trial will be rate of patient with an undetectable PSA level at 6 months after treatment start, and secondary endpoints will be biochemical progression, radiological progression, overall survival, cancer-specific survival, and quality of life measured with EORTC QLQ-30 and EORTC QLQ-25 questionnaires. At the current status, 80 patients have been enrolled, consisting in 45% of the final sample size. In conclusion, results from Arto trial show that the addition of SBRT to first-line abiraterone treatment yielded a significant increase in 6 months biochemical and complete biochemical response. A significant benefit in progression-free survival was detected in favor of the combined regimen. But of note, this benefit was translated as well in clinically meaningful endpoints such as freedom from the need of additional treatment and freedom from appearance of new metastases. Phase 3 trials are warranted to test the benefit of SBRT addition to systemic therapy in larger cohorts. Thank you very much for the attention.
Thank you, Giulio, for this excellent overview, and I must admit that these results were even better than I would ever dreamed of. These were very spectacular, and I think this shows that these randomized trials are worthwhile doing. Without further ado, because I would have like 1,000 questions I could ask you on this specific topic, but I don't think this is the correct place. We will do that on a separate occasion. Yeah, I'm gonna mute you. Sorry, because you're causing an echo. I would like to pass on to Matthias now, who will take over for the rest of the presentation, do the introductions, as we have some very spectacular presentations coming up. So please, Matthias, take over.
Thanks, Pete. As you mentioned, we stay spectacular in the field of randomized clinical trials in the field of oligometastatic disease. And it's an absolute pleasure to announce the next speaker, Jillian Tsai. She's Associate Professor at the University of Toronto. She's working at the Princess Margaret Cancer Center, where she's the site lead of the palliative radiotherapy and the oligometastatic program. And we, of course, invited her to present us the results of the CURB trial, which have just been published in The Lancet a few weeks ago. Jillian, many thanks for joining. At least that's what I'm hoping for. Oops. Let me see.
Hi, Matthias. This is Pablo. I don't see Jillian Tsai on the call currently.
Okay, so maybe she's a few minutes delayed because she mentioned she's currently on a visiting professorship. So I saw David already. David, is that correct? David Palma? Maybe he's...
Hi, Matthias.
Hi. So David, would you mind if we change order and you would present first?
Yeah, no, that's fine. Sorry, my mic was a bit slow to unmute. Yeah, let me just share my screen.
No worries, but I will still give you a kind of an introduction. I mean, everyone knows you, but I looked at some of your older publications. In 2014, you published a paper in Nature Reviews, the oligometastatic state separating truth from wishful thinking. And maybe people have thought at this point of time that you were just writing a review article with many, many famous people, but effectively you're on a mission since 2014, kind of proving us that this is not just a wishful thinking. So many thanks for presenting your most recent clinical trial in the field of oligometastatic disease, the STOP trial. David, many thanks for joining.
Thank you, Matthias. Matthias, can you see my slides?
Perfectly.
Good. Hello, everybody in Europe and all around the world. I'm looking forward to seeing some of you in Glasgow at the upcoming ESTRO meeting. This is a presentation of the STOP trial, which was presented at ASTRO, which is the, it's the ESTRO from this side. And it was presented by Devin Schellenberg. So Devin sent me his slides. Devin doesn't have his own picture on his slides. I added his picture here just to show that Devin was the principal investigator. Devin is a radiation oncologist in British Columbia, which is on the far west of Canada. And if you're going to Canada, which I welcome all of you to do, the best bet is to go to the West Coast where we have Vancouver and Victoria. So I'm going to tell you today about the STOP trial. The results are just presented this year. And I think there were a lot of interesting lessons from the STOP trial that go beyond the data themselves, but just speak as a whole to our specialty and how we are going to design the next set of trials. The STOP trial was part of our Capri group of trials. So Capri is, I'm of Italian descent. Both my parents are born in a city called Pescara. So I wanted to give this an Italian name, and it's the Canadian Pulmonary Radiotherapy Investigators Group. But we really like to think of the island of Capri, which is more beautiful than many places we have over here in North America. So Capri is a Canadian initiative of like-minded investigators that try to open each other's trials. All these trials are actually run out of my center, but we have the principal investigators distributed around the country, and these were all donor funded. And in about 2015, 2016 through 2018, we launched 5 trials. 3 of them were randomized, and all 5 completed accrual. And I'm going to talk to you about the second one here called STOP. All of them have been reported except for PET Boost, which will be reported this year. And soon we'll be launching the second generation of Capri trials. I'll have to think of maybe another island to name them after. So I'm going to talk to you about STOP. So this is the STOP final trial schema. It's enrolled patients with up to 5 oligoprogressive lesions from any solid tumor while they were on systemic therapy. And they were stratified. They were allowed to be on cytotoxic, non-cytotoxic, so that would include immunotherapy, hormones, and targeted agents. And they were randomized in a 1-to-2 ratio between standard of care and SABR. Now, SABR would be delivered to the progressive sites, and you would continue with the same systemic therapy. Whereas with the standard of care, you had the option to switch to a new agent, continue the current agent, or observe, because sometimes there's no next line of treatment. And then the follow-up, as you can see there, was pretty standard. Now, this was a trial for all histologies, and people might say, well, why did you do all histologies? Well, we actually tried to do only one histology. And so this is called STOP trial and tribulation. So this was actually called STOP non-small cell. And in the protocol, we had some go, no go targets where accrual had to be at a certain level or the trial was needed to be revised or stopped. And with non-small cell only, despite very motivated investigators in Canada, we were unable to accrue with that histology only. And so we met as a group and we had to make a decision. Do we stop the trial or do we expand to all histologies? And we decided that having an answer to an imperfect question, meaning that the trial with all histologies is imperfect, is better than having no answer at all. So we decided to expand to all histologies. And I think this really indicates how hard this trial is to accrue. We've been able to accrue some very difficult studies. You know, the SABR Comet trials we've been able to do in Canada, they've accrued. We were even able to do the ORATOR and ORATOR 2 trials in Canada, surgery versus radiation, but we couldn't do that for head and neck cancer. But we could not do this. But we did get it done with all histologies. So just a few boring but important slides. The inclusion criteria, so they had to be 18 or older. They had to have a histologically confirmed malignancy, reasonable life expectancy, ECOG 0 to 2. There was no maximum number of lesions, so you could have oligometastatic or polymetastatic disease. You had to be progressing in up to 5 lesions that had not been ablated before, and no more than 3 oligoprogressive lesions in a single organ. And in terms of what they had to be on for systemic therapy, they had to be on systemic therapy for at least 3 months in total, and within the past 6 weeks with some kind of initial disease control. So they had to have some benefit to the systemic therapy before that. They had to be restaged within 12 weeks, and we restaged them with CT imaging or PET CT imaging, and then some very basic laboratory and quality of life instruments that we used. So as I mentioned before, in the SABRE arm, you had to remain on the same systemic therapy because the idea is you're going to try to get more length out of your immunotherapy or your targeted agent. It's working everywhere, maybe except for a few lesions. So you have to stay on the same systemic therapy. In the standard of care arm, we didn't think we could mandate the same systemic therapy because then people are on a systemic therapy that doesn't work. And also some funders will not fund a systemic therapy after progression. So it allowed patients to switch, continue the current agent, or discontinue if there was no other option. And that had to be pre-specified at the time of enrollment. And we were allowed to give palliative radiation for symptom control, these types of fractionations. In both arms, if there was a brain lesion, you could still give SRS or SRT regardless of arm, but there had to be another lesion in the body that was progressing that you could randomize upon. And then people always ask about disrupting or breaking systemic therapy. Rather than taking this, I'll refer you to Dr. Guckenberger's recent paper on systemic therapy and when to hold it, when not to hold it. But basically for the oral agents, the TKIs, 48 hours, immunotherapy, this was a long time ago, 5 days between the start of radiation and the last dose of immunotherapy. Hormones we continued, and cytotoxic also had 5 days of a break before and after. The primary endpoint was progression-free survival. The secondary endpoint, overall survival, toxicity, quality of life, and these other things, which actually I'm not presenting in these slides today, but they will be in the paper, which is under review. And this was our sample size calculation. So from good data from before, we assumed that the PFS was going to be 6 months, and we thought that a 6-month improvement in PFS would be very reasonable. And we had a 1-to-2 randomization, accrual over 4 years, 1 year of follow-up, and 5% allowability for dropout. With a 2-sided alpha of 0.05, we needed 90 patients. So just looking at the demographics here, these are just the percentages here. So the majority was lung in both arms, so there was some more lung in the control arm. Most patients had lung as the radiated site, and most patients had just 1 progressing lesion. Some had 2, very few with 3, 4, or 5. So this is just a few progressing lesions in total. Now, I'm going to take you through the consort diagram because this is really telling as to what can happen with these trials. So we randomized 90, and it was a 2-to-1 randomization, so we had 59 and 31. In the SABRE arm, things went fairly according to plan. 1 patient, interestingly enough, all lesions disappeared in the radiation simulation scan, so potentially a late response to their systemic therapy, potentially non-malignant metastases, quote unquote. But this arm was really where the difficulty was. So 6 patients in the control arm received high-dose or ablative therapies instead of palliative doses. And this was for a variety of reasons, mostly a strong patient preference. Some people sought out treatment elsewhere. And you might say, well, okay, this trial is this a limitation of the trial? Yes, it is, definitely. But I think we have to realize that this is very much human nature. We're seeing the same thing on Comet 10, not to this extent. We're seeing the same thing on many of our trials where if you're a patient and you very much want to get a treatment, you will go to get the treatment, and that's certainly within their right. The other thing that happened is in the standard arm, 3 patients withdrew immediately after they were allocated to arm 1. So they said, okay, I'm on arm 1, I'm dropping out of the trial. And there's honestly not much that you can do to prevent that. So there's certainly contamination of the control arm with these 6 patients who received SABR, and then a bit of loss of power with 3 patients who withdrew immediately. But despite that, you might think, well, maybe you'd see a trend based on the patients randomized. We did not see a trend for PFS. This is a SABR arm here, a bit better at the beginning, and the curves cross, and a bit worse at the end. But the p-value is nowhere near significant. We can talk about crossing curves and the implication on hazard ratios, but certainly nothing here to suggest a benefit in terms of progression-free survival. In terms of overall survival, P of 0.22, we can't conclude anything here, but you might imagine that with a larger sample size, maybe you could. It's hard to say. This is negative. Negative, but interesting that the SABR arm is on top. Quality of life, much like we saw from the data from OligoCare, quality of life was fairly stable. This is the p-value between the arms. Also, over time, the quality of life was quite stable. Also, like we just saw with OligoCare, the toxicity rate was very, very low. This is a very safe treatment overall. So a few exploratory analyses and some comparisons with the CURB trial. This is the old reference to the CURB trial before it was published in The Lancet, and I look forward to Dr. Tsai, who is a new addition to our Canadian team here, which makes us very happy. She's going to be presenting the CURB data in a few minutes. So Devin made this comment: every time you do a subgroup analysis, Justin Bieber writes another song, and the quality might not be very good. So you have to be very, very cautious, because the more songs Justin Bieber writes, the less impactful they are. Unfortunately, he's also Canadian. So when you look at the lung primaries, as we know in CURB lung, we did see a difference, but in STOP, we did not. This is the SABR arm here. Whereas in breast, although the numbers are very, very small, sorry, my computer is lagging. Here's breast. The numbers are extremely small, but surprisingly enough, we did find that with SABR in the breast group, we did see a benefit. Okay, but this is extremely small numbers, hypothesis generating, and I wouldn't put too much weight into it, except to say that we need to learn more. Like Justin Bieber songs, it leaves you kind of unsatisfied. Looking at the crossover, so we just plotted, this is exploratory, control arm, no ablative treatment, which is the lightest blue. This is PFS for them here. Control arm, ablative treatment, and the SABR arm. You don't really see anything coming out for PFS, but for OS, the control arm, if they got the ablative treatment, is up here. Control arm, no ablative treatment down here. There's a bit of immortal time bias here, as some of you will realize, that you have to be alive and your lesion still there for you to be able to receive ablative treatment after randomization. So this is not to be overweighted in terms of making your decisions. So in conclusion, we did not observe a difference in PFS or OS in this basket histology trial. There was substantial use of higher radiation doses, SABR and RFA. I didn't mention that, but the ablative treatments were all three of these things. Unlike CURB, didn't see a response in lung cancer specifically. We need more trials in this space. There's a bit of a design challenge. This is something that's kept us up at night for many years, and I think Dr. Tsai has some good ideas on how we can handle this issue. But the issue with the oligoprogressive trials are this. So we have a patient who has oligoprogressive disease, and so one arm is going to be SABR plus an old drug, because they're going to stay on the drug, right? That's the whole point, is to get more time out of your immunotherapy. But that old drug might be showing signs that there's resistance to it in this patient. The other arm is going to be no SABR plus a new drug. So could this new drug work better than the old drug? It's really two things that are changing when you do these comparisons, and it might not really be a fair comparison. That it's hard to really tease out the effect of SABR. One idea is potentially to use a metric called PFS2. So you go to the second progression after randomization, so that they would progress. Then you count the time when they get this new drug that they would get in this standard arm here. But there's some issues there, right? Sometimes this next drug is not appealing. Maybe the patient doesn't want cytotoxic treatment after IO. Maybe there's no drug. Maybe the patient wants a break. So it's not really easy to design these. And just some opportunities and challenges as we look towards the next generation of oligoprogressive trials. So the challenges are that it's difficult to accrue patients to a non-stereotactic, non-ablative arm. We found the deviations were significant, and Dr. Anand Swaminath, who many of you know, was the PI of the Leicester trial. He said that maybe one way to think of these data is that for better or worse, physicians have in their mind changed what they think standard of care is, and they think it's standard to treat, and that they were no longer comfortable randomizing, and that's certainly up for debate. Our numbers are small, and the subgroup analysis is not robust. But to end on a positive note, there are some opportunities. In Canada, there's a big appetite to try to redo a trial in this space. I think Dr. Tsai will be talking about this. Ideally, histology specific or large enough for subgroup analyses. And then something for us all to think about is, what do we do to drive accrual? How do we deal with this accrual issue? One idea is that you don't offer SABR off trial. And so for Orator and Orator 2, we did not offer TORS off trial, so patients went on trial. The second idea, so all the centers would have to agree to that. Second idea is that everybody on the standard arm gets a palliative dose. So the experimental arm gets SABR, the control arm gets a palliative dose, at least that there's some treatment and patients won't drop out. And the third idea that's actually being considered very seriously in a trial that's being designed in British Columbia is that we would actually double blind it. And so people would not know which arm they are on. It's been done in radiation oncology, not enough. But we're jealous of our medical oncology colleagues where their patients either get a drug or a placebo, but nobody knows. So then nobody drops out, right? And there's some benefit to that for sure. So lots of complex issues. Thanks for listening, and thanks for including me today.
Many thanks, David, for, as always, an excellent presentation. What I would propose is then that we continue with the next presentation. Jillian Tsai has joined us, presenting the CURB trial, and then discuss the two trials together, because these are two trials in a very similar field, and maybe we can learn from both trials being discussed together. So Jillian, I've already made an introduction. Many thanks for joining. Congratulations again for your successful trial, the publication, and as I learned, for joining Canada. Jillian, the floor is yours.
Thank you. Can you guys hear me and see this?
Perfectly.
Okay, I'm actually at MD Anderson right now. So the internet is the public internet, so I hope it works. Okay. So I'm going to directly jump into the CURB trial and my disclosures. I'll skip the introduction. So the CURB trial is a phase 2 open label randomized study of oligoprogressive non-small cell lung cancer and breast cancer. A couple of things. The reason why we eventually decided for non-small cell lung cancer and breast cancer wasn't like a biological decision. It was more like more because of the convenience per medical oncologist recommendation. Like these two sites, there were suitable patients to study. So the population for the CURB trial is very similar to the STOP trial. Oligoprogressive 1 to 5 lesions, no upper limit of total stable lesions. It was a 1-to-1 randomization to no SABR or no SBRT versus SBRT plus the same systemic therapy. So exactly the same design, but it's a 1-to-1 randomization. Initially, we aim to target just the non-driver mutation positive non-small cell lung cancer and triple negative breast cancer patients, but later we opened the accrual to all non-small cell lung cancer and breast cancer patients. So the sample size was initially proposed to be 160 patients with 80 patients each arm. This was a single institution but multi-center trial. You can see that the patients were accrued from the tri-state area, New York, New Jersey, and Connecticut, Long Island area, all the regional sites of Memorial Sloan Kettering. The primary objective was progression-free survival, and secondary objectives include overall survival, toxicities, PRO, and time to initiation of new systemic therapy. We also collected blood and imaging markers. So at our interim analysis of 106 patients, we had a little bit more non-small cell lung cancer patients than the breast cancer patients, but the randomization was almost equal allocation to both arms. So at the end, we had 55 patients in the SBRT arm and 51 in the standard of care. So this is the study population. You can see that there are, for the breast cancer patients, we had about a third of them that was triple negative. And you can also see that most patients had more than one site of oligoprogression. So there were not those patients with just single progressive disease. Many of them had multiple sites. And also more than half or so patients had what we would traditionally call polymetastatic disease, more than 5 total sites of disease. Because of the large population in non-small cell lung cancer patients had no driver mutation, most of them also had prior immunotherapy. In terms of other distributions of metastatic lesions, a fair portion of them had prior brain metastases treated either by SRS or whole brain. So at the interim analysis, when we look at the progression-free survival as an overall endpoint, you could see that it was significant in the radiation arm compared to the standard of care arm. And because of the significant result, the study was the study was closed due to efficacy. And when we did our pre-planned subgroup analysis, and in contrary to Davis and Devon's trial, we didn't see any effect in the breast cancer group, and most of the effect was seen driven by the non-small cell lung cancer. There was probably about 4-fold difference in hazard ratio in progression-free survival comparing radiation versus no radiation. I want to talk a little bit about the pattern of possible progression. When we talk about what is the progression after oligoprogression, how does that differ in SBRT versus no SBRT arm? You can see that in those who had radiation, when we say stable disease, really they were previously thought to be stable disease that didn't get radiation and that didn't progress. For patients who progress after radiation, they could progress in untreated, previously thought stable disease, turn out not to be stable, or they could grow new lesions. In those who didn't get radiation, the stable disease it's extremely rare, almost none, that the previously thought the red oligoprogressive lesions were perhaps not oligoprogressing, just random fluctuation of disease. Again, this is rare. But for those who progressed, they either progressed into untreated sites or they grew new lesions. So why is it important? When we look at the pattern of progression in the curved patient, we can see that in the breast cancer group, regardless of radiation or not, basically most of everyone grew new lesions, indicating probably in that breast population, we caught them too late. They were just growing disease everywhere. They were not really the true oligoprogressive phenomenon that we wanted to capture in the study. Whereas in the lung group, you could see that in the no radiation arm, the untreated, previously progressive, oligoprogressive, untreated lesions, they continue to progress without radiation. So probably suggesting that indeed, some of these patients indeed had a true oligoprogression phenomenon of resistance in certain selected clones. For the CURB trial, we also had blood samples available in about half of the patient population. Because the study went through the COVID era, we were not able to collect a lot of blood samples when everything went remote. But about half of the patients in the 106, they had at least pairs of blood samples pre and post randomization. So it's either pre and post radiation or pre and post no radiation. So we were analyzing, this is a busy slide, but basically we used the in-house ctDNA assay to look at the changes of ctDNA levels pre and post randomization. When we chose this assay, it's in-house based on the prior tissue profiling, actually specifically for breast and lung. So we thought that this assay was adequate for our analysis. The assay was proven to be about 92% sensitive for calling a mutation with a 0.5% allele frequency without prior mutation profiling, meaning that the patient didn't have, other than the blood sample, they didn't have the tissue analysis to correlate. But if they had a tissue, like prior tissue analysis, there's a 99% sensitivity. So here's this workflow of the patients that we had paired samples, baseline and 8 weeks. And then after excluding all these patients without sufficient samples, we were left with 23 cancer and 17 non-small cell lung cancer patients. But you can see that there's correlation between the ctDNA fraction from the tissue in terms of detecting the specific mutations, and also cell-free DNA-based blood metrics is actually really good. So this figure is actually very interesting and also very telling. That's also correlates with our clinical finding, in that if you look at the left two panels, the breast cancer no radiation versus radiation. Can you hear me?
Yeah, everything.
Yes, we can. But everyone else, muted. Please mute your microphone.
Oh, okay. I'm sorry. Let me just go back. All right. Where did I lose? Can you guys see my screen, or am I not sharing my screen correctly?
Yeah, we can see your screen.
We can see your screen.
Okay. All right. So if you look at the left two panels, it's actually very interesting because so this is a baseline in 8 weeks, and the y-axis is just the quantitative analysis of the cell-free DNA. So you can go up and down depending on the overall cell-free DNA burden. So you can see that in the breast cancer cohort, it didn't matter whether they got radiation or not. The levels of cell-free DNA just everywhere. There's no correlation, meaning that, and actually most patients continue to have increase in the cell-free DNA level, indicating that probably, there disease brewing elsewhere that were not initially captured clinically. So they were probably not true oligoprogression. Whereas in the non-small cell lung cancer, for the majority of patients after the SBRT to the progressive sites, the total tumor burden in terms of cell-free DNA metrics did decrease. So perhaps we were indeed treating the resistant clones. So I thought that these metrics were pretty consistent with the clinical findings. And then people would ask, what about, ER/PR status? Again, we had really few breast cancer samples, but if we analyze them differently, separating ER positive versus negative, we didn't really see any clear pattern either. So in conclusion, the CURB trial showed PFS benefit in the non-small cell lung cancer cohort only, not in the breast cancer cohort. And I thought that the cfDNA test results were consistent with the clinical findings, and that would perhaps be interesting for future validations in the more specific subsets of patients. Thank you, guys.
Thanks a lot. Maybe Jillian and David, if the two of you could join the discussion, we have a couple of questions in the chat. And the first question I would address the both of you. We have seen 2 trials in the field of oligoprogessive cancer. I would say none of them was being negative because they are both very important and will guide us to design the next clinical trials and will inform us about clinical practice. What was, from your perspective, the biggest learning experience of the other trial? David, you want to start?
Yeah, well, the biggest learning experience of the other trial was actually the extent to which an investigator can really drive accrual. And this is a compliment to Dr. Tsai. Dr. Tsai, you didn't get into it in this talk, but you talked about it publicly on many occasions, in that you were able to individually go through the list of the medical oncologists and see who is progressing, and then say to them, you know, before they came to clinic, say, hey, you know, I have this potential patient, could I consent them tomorrow? And I think that what that shows is that we just need to be creative in how through these patients. I think, Dr. Tsai, you just demonstrated that it can be done. It's very labor intensive, I think you would say. Dr. Tsai, no, it took a bit of work, but it can be done.
It's a lot of work, yes.
Dr. Tsai, what was for you the most important learning experience from STOP?
You know, I think it's actually the patient population. I don't know about this. I was actually very intrigued about your breast cancer patient. That I think the most important learning experience is that, you know, even for the oligoprogressive patients, it's just such a heterogeneous patient population. It's basically at any time of their cancer trajectory, they can have oligoprogression. So this is not like oligomet. So I think David perhaps captures some of the patients, especially the breast cancer patients, way earlier than their disease trajectory. And I think that's the most important is timing. I think, say, oligomet, there's only a small window, but for oligoprogression, they can have progression and switch drug and have another oligoprogression. But then after too many lines of systemic therapies, they are no longer the same biology. So I think the most important especially for David, your trial, is that I think many of your patients were actually earlier in their disease presentation. So that's actually the patient we should be focusing on.
And if I could just build on what you said, Jillian, I think that might also have to do with the fact that ours, you know, your trial was run at one of the biggest, most famous centers in the world, where I think patients are going after having tried multiple lines, maybe even elsewhere, and they're looking for what's the next thing that can help me. Whereas our trial was more of a run-of-the-mill. They're all academic centers, but it's not like they're going to like the, you know, most prominent, one of the two most prominent U.S. centers. I said one of the two because I know where you are right now at MD Anderson. We have to be mindful that there are two, but it might just be that drives some of the selection.
There's a couple of other
I
questions.
think our trial was actually a dump of whatever they didn't want the patient, because for the breast cancer patient, they were like, there's no more line. Why don't you consider this radiation trial? So it's a very, very different patient population.
David, you made a strong emphasis on how to design the next clinical trial generation, how to kind of boost recruitment. There's a comment by Clive. Clive, many thanks for joining. Why not consider pre-randomization approach? We do this for stablemates, a clinical trial comparing SBRT and segmentectomy. This increased our recruitment by a factor of 4 compared to the failed SABRE-2 trial. Any ideas on that?
Yeah, so pre-randomization, I haven't done it for any of my trials. There's a suite of Canadian trials that's doing it. There's one Achilles heel to pre-randomization, in that if the patient doesn't accept the randomization, then you're out of luck and the trial loses its internal validity, right? So basically pre-randomization would be that they're randomized, for those who aren't familiar with it, it's also called Zellen's randomization. So you come to clinic, so Matthias, I'd be coming to see you and you'd say, hey, Dr. Palma, or Mr. Palma, Dr. Palma, you've been randomized on my new study to get the standard arm. Do you agree? And if I say yes, that's great. But if I say no, then the whole thing falls apart, unfortunately. And there's certainly bias. Which patients disagree? It's probably the fitter ones, maybe the ones who are more motivated to seek treatment. So I think pre-randomization is a tool, but it's not perfect.
Yeah, I agree. I think if you get the patients earlier, I think the problem is that the patients can go either way. Like they may or may not turn out to be eligible. So like you would also take a huge number of patients to get your desired the actual sample size. So that is a huge effort as well.
A question to both of you, which is addressing the endpoint, that this was discussed initially by Corinne McFarvin, and also by Joachim Witter. Progression-free survival was a primary endpoint in your trial, and you have a clinical situation where you have a patient having polymetastatic disease, having systemic therapy, she progresses. And then you treat with SBRT, and the patient might still progress in just a single lesion, and still the patient will reach the endpoint. But you could add another course of radiation. So what are about the relevance of progression-free survival in this scenario, and what would be alternative endpoints being used, which, as Corinne stated, might be more reflecting the view of the patient.
So
Dr. Tsai, do you want to go first?
Yeah, I will take on this question because we're designing the phase 3 trial, and this question constantly came up. And from the medical oncology standpoint, everyone wanted overall survival, right? But as RADA, we would argue that the progression-free survival accompanied by a meaningful patient-reported outcome endpoint is just as valid, if not more so, than the overall survival. So I would say probably, so there are a couple ways of doing it. You, as David, you suggested, you can look at the PFS too, looking at how much longer you can keep this patient on this current systemic therapy. So you keep offering radiation. And it would be really cool to actually accompany this with the blood samples, because in clinic, I have started to see that, like the liquid biopsy is becoming more standard. In some patients who were on TKI, they would develop this new EGFR mutation that's resistant to specific TKI. And I would be asked to irradiate those the patients. So it would be like, you can irradiate and then you can measure whether that resistant TKI mutation is gone, right? After your radiation, then you stay on the drug, and if it's still present, you probably want to add a new drug while continuing to offer SBRT down the road. So I think I do think PFS is a great endpoint, accompanied with the biomarkers and also the patient-reported outcomes, because they usually tolerate very well the targeted therapy or sometimes immunotherapy before switching to chemotherapy.
Yeah, I would agree.
Asking an immediate question before I switch over to you, David, addressing the ctDNA. How valuable is ctDNA as a surrogate endpoint in patients having upfront polymetastatic disease and then oligoprogression? I can believe it's very valuable. You had many patients which had oligometastatic disease overall and then progressed in 1 or 2. So effectively achieving the majority of the disease burden. When I remember our EORTC and CLUK cohort trial, the majority of patients had a full load of cancer and then a progression in just 1 or 2. Could you elaborate on these two clinical situations where you treat most of the disease or only the oligoprogressive?
So if the disease is stable, we could treat or not treat. I think that's it depends on the location, I suppose. But I would always advocate for treating if we could.
Maybe, sorry, I interrupted you.
Yeah, no.
I'm so sorry.
No. The idea of the endpoints is so interesting because there are a few, let's say, inconsistencies in the oncology world, right? I think the first inconsistency is that we often see that med-oncs argue for OS. You need to show OS, need to show OS, but most of the med-onc trials now are no longer showing OS as their primary endpoint for the phase 3. Over here on this side of the Atlantic, only about 30% of the FDA approvals are for OS. So they're not using OS. But then there's a whole common sense oncology movement that says, well, PFS isn't great either because patients don't necessarily care about PFS. What do patients care about? They care about length of life, which is OS, and they care about quality of life. The other difficult thing is that, if you have a few lesions, maybe your quality of life is fine. And so we're not gonna improve that. I think things around time to systemic therapy or time off systemic therapy, I think that's really, really important. I see Dan Gomez in the comments has suggested there'd be an endpoint around that. It would be a really, really good idea because we find that patients really want to be off of systemic therapy. And we were even seeing this in Comet 10, where in Comet 10, you have to specify what systemic therapy you're going to give. It's supposed to be the same regardless of randomization. But often what's happening is the patient is randomized and they get the saber and they say, well, maybe I'll take a break from my FOLFOX Avastin or FOLFOX without Avastin that I've been taking for so long. So that's really important to patients. You have to think about how to design it. And, there's been a lot of chat a lot of discussion in the chat about, bigger studies and hazard ratios and that kind of thing. And why are our studies going after hazard ratios that are a bit aggressive? And I thought I was playing around with my stats software here. I just wanted to show something that is really informative, that really makes us think about the trials that we design. So Sabre Comet, we got lucky because the survival in the standard arm was pretty short. The hypothesis was pretty short, so you can get away with a short hazard ratio. But a lot of our trials are looking at a hazard ratio around, looking for sort of 0.6, 0.65 in this area. LU002 is looking for 0.55. This is the sample size you need for that type of a hazard ratio if you assume the median survival is 1 year. So you need about almost 200 patients for this very aggressive hazard, which is really aggressive, right? So let's do a trial where we're looking for a hazard ratio of 0.7, which is what the MEDONC trials are. Well, now you need 400. And can we accrue that in radiation oncology? Maybe. And then you get to these hazard ratios where some MEDONC trials are, and you need a sample size of 1,000. So we're stuck between these different factors where accrual is not easy. People want to be treated off trials sometimes. And then we really want bigger studies. And I think we can do them, but I think it just requires us to really think about what are the endpoints that we are going to use. And as Dr. Faber-Finn said, what's most important for patients? And I think it revolves around quality of life, time off systemic therapy. Those are quite important.
Maybe one last question, which was also in the chat before. The standard of care is changing rapidly. Maybe even during we are kind of conducting our trials. And if the trial is being published, the standard of care will be different compared to when we initiated it. How much is that a concern? So are we testing a proof of principle and saying the addition of local treatment to systemic therapy, it just works irrespective of systemic therapy? Maybe even say that the more effective systemic therapy, the better the local treatment can kind of become. Or is it vice versa and saying, well, we need to prove the benefit of our local treatment every time we have a new standard of care? And there's obviously a gray line in between. What is your opinion on this question?
So I can answer this. So I would say bring it on, because so the purpose of radiation is to prolong this current. Okay, let's say this is the first line drug, right? So the purpose of radiation is to eradicate the resistance and then prolong their duration on the first line drug. And there may be a second line that's new compared to before. But then even if you switch to the second line, supposedly second line by definition should be less effective than first line. So by prolonging the patient's time on the first line, if there is a true benefit of really, optimizing their potential, then we will still see benefit regarding whatever the second line might be. So I think the question is more like if we can capture these patients earlier. Obviously, if you are down to second and third line drugs and you capture them really late, they're being mixed and matched with different newer drugs, that may be different. So I would argue that in the next trial, we should focus more on patients in the early stage of their metastatic disease on first line. And then it sort of doesn't really matter as much for the second line anymore.
Yeah, that's a good point. And the other addition I would make is let's do a thought experiment on your question, Matthias. Let's assume that we're going to decide that for every new treatment that comes out in MEDONC, or every major treatment, we're going to do a trial to show that Sabre is helpful. So new immunotherapy comes out. So Matthias, you and I, we're going to launch a trial, right? And even if we're fast, we're not going to get a result for 10 years. By the time, Sabre Comet 10 accrued for 5 years. That's plus we're waiting for results. So it's like 10 years, basically, maybe 8 or 9. So you and I were going to scramble to launch a trial. We're going to do it. Everyone's going to help us. And then by the time that happens, there's a new drug, right? I think by nature, it's just, we're always going to be behind. And so I think, and that's unavoidable, unless somehow you're going to start testing radiation with drugs that are in the pipeline, but then that's going to be a huge waste of time because many of those drugs will never come to clinic. So I think we have to just accept that we have to try to draw conclusions that might be, we hope, applicable across multiple different types of histologies and multiple, I misspoke there, across multiple different types of systemic therapies because they are going to change over time. So that's my view on it. Ideally, we would have a trial for each drug, but I just think it's not possible.
Thanks a lot. And if we want to do a back of the envelope calculation, just add the stock values of all companies in the field of radiation oncology which could fund such a trial and compare it with all the accumulated stock values for all pharmaceutical companies. And then we know how large our resources are to kind of match the systemic therapy trials one by one with a radiation oncology trial. Thanks for the two of you for excellent presentations and discussions. And it's now time to move over to the next speaker, who unfortunately will not be with us because it's late night in Australia. Shankar Siva from Australia, Peter Mack. He has done his trial in the field of single fraction SBRT for oligometastatic disease. Why is that being important? Dr. Palma has told you about trials which not only enroll patients with a solitary metastasis, maybe 5, maybe even 10, maybe even more than 10. And can you imagine a patient having 15 metastases and each metastasis being treated individually with 15 fractions? Impossible. 10 fractions, impossible. 5 fractions, impossible. So we need to go down, and we do have evidence. And I hope we can learn from the talk of Dr. Siva, and also we hope to shed some more light into this field from OligoCare. You know that we are currently investigating the so-called TWIX concept trials within a cohort, addressing randomized questions within a registry trial. And the first question we want to address is single fraction versus multiple fraction. And this is kind of preparing the field. So please start the video.
Yeah, I'll go ahead and share the video. Let me know if you do not hear anything.
I don't see anything yet. You need to share the screen.
Yes, I'm on it. 2 seconds, please.
Perfect. No, the audio is not working yet. I can see.
You cannot hear the audio?
No, I can't.
Okay, let me try like this. Let me know if you hear.
When you share, you should select include the computer sound.
Say again, Enrico.
I was hoping that would have been Shankar.
When you share, you need to de-share, and when you share, you have the option at the top that says include computer sound.
Okay. I'll reshare the screen. 2 seconds. Sorry, yeah.
Thought you were going to do an Australian accent, Matthias, there, but we get Shankar's voice instead.
Okay, thanks, Enrico. I think it should work now.
I'd like to thank the organising committee from EORTC and ESTRO that have invited me to give this talk on the experiences and evidence for single fraction SBRT. My name is Shankar Siva. I'm a radiation oncologist at the Pinnacle McCallum Cancer Centre in Melbourne, Australia. I'd like to start with this topic. We're just asking the question, why single fraction? It often seems to us in radiation oncology that it's a race to the bottom, where we're trying to reduce the fractionation schedule. But I'd like to convince you that this may actually be a good idea by the end of my talk on single fraction experiences. Firstly, with ultra-high dose per fraction radiotherapy, we're beginning to understand that there's different mechanisms of cell kill than what we're typically used to with the double-stranded DNA breaks and mitotic catastrophe. These include other types of cell kill with endothelial apoptosis and vascular injury, engagement of the ceramide and sphingomyelinase induced cell death pathways, and pro-inflammatory signaling, which may be useful for adaptive immunity. When we're trying to balance between single fraction SABR versus fractionated SABR, it really comes down to the potential disadvantages or risks versus the advantages. From a risk perspective, there's a risk that radiobiology for single fraction high dose treatments are not completely understood. There's also a risk of toxicity. We are taught that fractionation is one of the inherent principles to potentially take advantage of the difference between normal tissue toxicity and tumor control probability. There is also the risk of geographic miss. When taking all of our treatments and putting them into a single treatment episode, there is a risk of any type of error being compounded for the entire treatment. There's also the idea that centre expertise may be a limitation, as some often robust SABR program is required to be able to deliver single fraction treatments on a consistent and regular basis. Some of the potential advantages around new biology. We know that SABR, particularly single-dose SABR, may have vascular effects, which may be more potent for cell kill. There is a controversial potential for that single fraction treatment might be immune stimulating as opposed to multi-fraction, although this is controversial. And there's a cost profile and patient centricity of single fraction treatment. Single fraction radiotherapy is often a lot cheaper than multi-fractionated schedules, and it's very convenient for a patient to arrive just once for an episode for the entire treatment, and allows for machine efficiency within a busy clinical department. One of the issues with single fraction SABR is modeling the actual dose treatment is very difficult. This is 3 curves here: the linear quadratic curve, which is dotted, the actual survival curve observed, which is in the dashed line, and the extra slope there being a single fraction equivalent dose. The single fraction equivalent dose is from a universal survival curve as proposed by Park et al. In 2008. And it's trying to overcome the idea that the linear quadratic curve likely overestimates the potency of very high dose per fraction treatments. The curvature at the upper ends of doses is too high. Unfortunately, even with the single fraction equivalent, all models are ultimately inadequate, and empirical data is how we will derive whether the true efficacy of single fraction SABR is warranted. If we're trying to model single fraction SABR, for an example for this is the 3 randomized trials in the setting of lung. 2 of these in the context of primary lung cancer and Saffron 2 in the context of pulmonary oligometastasis. These studies all compared to 48 grade 4 as a standard arm, where RTOG 0915 had the single fraction of 34 grade using heterogeneity corrections. And this was estimated to be 48 grade 4 fractions using the single fraction equivalent dose model. In Saffron 2, the single fraction of 28 grade was also equivalent to 48 grade 4, but this was using a linear quadratic model for estimating the effects. So both arms had a BED10 of 105 gray. And in the Roswell Park randomized trial, actually the single 30 gray investigative dose is actually equivalent to 34 gray when using heterogeneity corrections. So it's not only the total prescription that's important, but the method of prescribing, which needs to be taken into account. Saffron 2 was a study that we presented at the ESTRO main meeting in May 2023. And it's a Trans-Tasman Radiation Oncology 1301 study. It stands for Stereotactic Ablative Fractionated Radiotherapy versus Radiosurgery for Oligometastatic Neoplasia to the Lung. This was a study where SABR was used in lieu of systemic therapy for patients with pulmonary metastasis. 90 patients were enrolled between 2015 and 2018 across 13 sites in Australia and New Zealand, and a total of 133 pulmonary metastases were treated. Eligible patients had 1 to 3 pulmonary metastasis of less than 5 centimeters in maximal dimension. There has to be originating from any non-hematological malignancy and in a non-central location. The randomization was either to a single fraction of 28 gray or 4 fractions of 12 gray to a total dose of 48 gray. And this was stratified by the number of metastases and also by tumor histology. Importantly, the prescription mechanism was quite generous. So we asked for D99 of the PTV to receive 100% of the dose in both arms. We asked for a Dmax of between 125% and 143% within the target volume. The median follow-up was 65 months. The primary endpoint was looking at severe toxicity at 1 year. And there was no difference statistically between the single fraction and multi-fraction arm. The high grade 3 or higher toxicities in the single fraction arm was 3% with no grade 4 or 5 events, and 5% in the multi-fraction arm with a single grade 5 event in the multi-fraction arm in a patient with underlying undiagnosed interstitial lung disease with multiple targets in the lung. Many of these patients enjoyed a long time without systemic therapy. No systemic therapy was allowed either concurrently or adjuvantly after the SABR was delivered. So on average, in both arms, the mean time to commencing systemic therapy was 30 months. From a cost perspective, a single fraction, unsurprisingly, was more cost-effective than multi-fraction. We conducted several surveys and questionnaires of both the patients using utilization of travel time as well as resource time by physicians and technicians on the machine. And the total cost from a single fraction perspective was 3,700 Australian dollars, and a multi-fraction perspective, $4,800. So single fraction saver was more cost effective from both a resource and patient's perspective. The long-term results were presented, and this includes the overall survival, disease-free survival, and a term called modified disease-free survival. To define disease-free survival, this is pretty standard. It's basically the use of SABR. Patients don't receive any concurrent or post-SABR systemic therapy, and if they're disease-free at 5 years, this is disease-free survival. Modified disease-free survival is a slight tweak on this concept where patients can have an oligo recurrence after being rendered initially disease-free, but they can undergo a second or more courses of SABR without any systemic therapy. And if these patients are alive and without disease using this strategy, then they are considered modified disease-free. With the median follow-up of 65 months, the overall survival is on the left, bottom left, disease-free survival in the middle, and modified disease-free on the right. Single fraction on the Kaplan-Meier graphs is in black, and multi-fraction is in red. And the overall survival was not statistically significant or different between the two arms, and neither was a disease-free survival, with a hazard ratio of 1.1 and 1 respectively. Modified disease-free survival was also no different between each arm. The estimates for overall survival in this cohort at 3 years was 70%, and at 5 years was 51%. So 1 in 2 patients with oligometastases to the lung are alive at 5 years using SABR as a primary treatment modality. When looking at the 3 different overall survival, modified disease-free survival, and disease-free survival plotted on a Kaplan-Meier graph, we can see there's a clear separation between the modified disease-free survival and disease-free survival. Indeed, at 5 years, there's a 14% difference and a median difference of 1.8 years versus 1.1 years between these 2 groups. So to summarize that, in this population where patients receive SABR in lieu of systemic therapy, 1 in 3 patients were alive without disease in the long term. That results in a 34% modified disease-free survival at 5 years and a median modified disease-free survival of 1.8 years. So what we were able to conclude from this study is that in selected patients with oligometastasis, SABR in lieu of systemic therapy should be considered the optimal treatment strategy. There's actually no difference in outcomes by the fractionation schedules that we observed. And with the current body of evidence, if we have already decided that local therapy should be the strategy used, we think this is the best evidence that there is for treatment, and SABR should be considered the optimal treatment option. This study was published in the Journal of Clinical Oncology, and the DOI to find this reference is here. So putting that study into context, this is a summary article that was published looking at prospective clinical trials of single fraction SABR for oligometastasis. The first 2 studies on the top are from our institution in this context of prostate and breast cancer, and the other 3 studies are studies predominantly of colorectal cancer, both in the lung and the liver. In prostate and breast, the control rates, which are on the right at 1 and 2 years, are excellent, between 93 and 100%. And even in the liver context for colorectal cancer, using very high dose single fraction between 35 and 40 gray, this is again 100%. So the question arises, when might single fraction be the best option rather than multi-fraction treatments? This is not in the context of oligometastasis, but a recent study from our group, from the International Radiosurgery Oncology Consortium of the Kidney, or IROC, published in Lancet Oncology 2022 in December. In this study, there were 81 patients with primary RCC that received a single fraction of SABR, commonly between 25 and 26 gray. Single fraction SABR was associated with reduced local failure risk and reduced progression-free survival risk, but not cancer-specific survival when compared to multi-fraction SABR. In the multivariable analysis, this persisted, but there was an increase in local failure risk for those patients receiving multi-fraction SABR. The hazard ratio of 6.1. These are the different graphs, with Kaplan-Meier on the bottom left being cancer-specific survival, in the middle being progression-free survival, and the local failure being on the bottom right in cumulative incidence. In the renal cell carcinoma space, again, this is an older study from Memorial Sloan Kettering retrospective that looked at 105 metastases from renal cell carcinoma in different locations in the body. The single fraction dose was between 18 gray and 24 gray, and the hyperfractionated doses were multiple, including 3 fraction, 5 fraction, and greater than 5 fraction schedules. And there was a much worse likelihood of local progression in the patients that receiving hyperfractionated treatment. This study was furthered by a randomized phase 3 trial, also from Michael Zalewski and the Memorial Sloan Kettering group, that was published in 2021. This had a basket histology trial of 117 patients with 154 metastases, and this is randomized to 24 gray in 1 versus 24 gray in 3 fractions. The median follow-up was 52 months, and there was no difference in either grade 2 or higher or grade 3 or higher toxicities. In terms of grade 2 plus toxicities, it was 11.7% for the single fraction arm versus 6.5%. And in the grade 3 plus toxicities, it was 7.8% versus 3.9%. In this randomized controlled trial, the cumulative incidence of local failure, which is the bottom left, showed that single fraction SABR was significantly lower risk of local failure. And this also translated into a lower risk of distant failure. On the bottom right, single fraction SABR was statistically significantly lower risk of distant failure than the multi-fraction 3-fraction arm. This also seems to be borne out in the spinal literature. This is a meta-analysis, also termed SAFFRON, must be a very popular title, of 3,000 patients and almost 5,000 lesions receiving either single fraction spinal SRS at 43%, multi-fraction spinal SRS at 20%, and conventional radiotherapy at 36%. Single fraction SRS was associated with improved local control rate at 92% as compared to conventional radiotherapy at 81%, whereas there's no difference between multi-fraction SABR at 82% and 81% in conventional radiotherapy. This was at a cost, though, with increased vertebral compression fracture rates noted with the single fraction literature at 19.5% versus multi-fraction, which was only 9.6%, so about double the rate. But there's no correlation between dose and vertebral compression fracture. So although the efficacy was higher in this study, the potential risk of compression fracture was higher. Which leads to the current era, where single fraction SABR might fit in the immunotherapy era. Is it like fire and water, or is it potentially yin and yang? Our own group, when we looked at the SAFFRON-2 study, also looked at a translational sub-study, which may shed some light, and this was published in 2021 in JAMA Oncology. As a sub-study of 18 patients from the Peter MacCallum Cancer Centre, we looked at blood collection for peripheral blood mononuclear cells at baseline, 24 hours, and 1 month after treatment. We analysed these PBMCs via cytophin FACS and looked at the plasma for cytokine expression. At 1 month post-SABR, there were significantly elevated levels in both arms of T regulatory subsets of CD4 positive, FOXP3 positive T cells, and also checkpoint expressing cells, so percentage of CTLA and PD-1 expressing CD4 and CD8 cell subsets. When comparing the arms between single fraction and multi-fraction SABR, there were some modest differences, but they were statistically significant. Differences between the CD4 positive T cell and CD8 positive T cell subsets that were expressing checkpoints of PD-1 and TIGIT. So except for CD4 positive TEMRA, single fraction had significantly higher percentage change in subsets of checkpoint expressing cells, which indicates that maybe this might be preferable if we are thinking about issues with checkpoint blockade. So what we were able to conclude from the translational outcomes is the optimal SABR fractionation schedule for immunogenicity is still controversial. This exploratory observation showed that SABR alone, even to very small volumes of the lung with very low tumor burden, was still able to induce systemic elevation and immune activation. And we were able to detect circulating immune cells and potentially altered functional status. The idea is that this could potentially be augmented with the addition of immune checkpoint blockade, and perhaps even that single fraction group with increased checkpoint expression might be the optimal partner. To take this further, our own group also recently published a study in 2022 which was called RAPPORT, which is stereotactic radiotherapy and short-course pembrolizumab for oligometastatic renal cell carcinoma. In this study, we had 30 patients with 83 oligometastasis treated with a single fraction of SABR. When not technically feasible, 30 gray and 10 fraction. There were 6 months of adjuvant pembrolizumab that followed, and the median follow-up was 2.3 years. 4 patients, or 13%, had grade 3 treatment-related AEs, so kind of additive toxicities with the SABR and the immunotherapy. And the disease control rate for greater than 6 months was 83%. Best overall response rates were exceptional, with complete responses in 40% and partial responses in 23, so 63% in total. If you look at the bottom right corner, that's the different RECIST waterfall plots looking at the maximum change in size of target lesions when divided by SABR in yellow and conventional radiotherapy in blue. There were deep responses in both and more likely also in the single fraction group when looking at the overall cohort. Our own experience with single fraction SABR was published in 2021 with our fellow Paulo Sagona from the Philippines. And this study looked from February 2010 to June 2019 at our single institution with 371 patients and 494 extracranial metastasis. This is a mixed basket histology population with 1 to 5 oligomets and a median follow-up of 3.1 years, so quite long. From a safety perspective, we only noted 12 patients, or 3%, that developed grade 3 to 4 treatment-related toxicities and no grade 5 toxicities. The median overall survival was 5.4 years, and the median progression-free survival was 1 year. But interestingly, when looking at that same concept, that modified disease-free survival, or in other words, widespread failure-free survival, which is that bottom left, and looking at repeat courses of SABR, at 5 years, a quarter of patients were free from systemic therapy and not having widespread metastatic disease. When looking at freedom from systemic therapy alone, which is the right Kaplan-Meier graph, a third of patients were completely free from systemic therapy at 5 years, indicating that this kind of strategy does have a way of preserving quality of life in these patients. Interestingly, the 5-year local failure data was exceptional with single fraction treatment of 8% local failures. And if we drill down on the bottom right, which looks at the local failure cumulative incidence graphs, distant failure is by far the dominant pattern of failure. However, the second most common pattern of failure in the green and the purple lines are local regional to the primary, which indicates maximizing the primary control may be important when pursuing oligometastatic disease. So our conclusions is that single fraction SABR is highly tolerable. 43% of patients are free from systemic therapy at 3 years and 35% at 5 years, indicating a role for repeat SABR approaches for maintaining quality of life. There's even a small subset of cure at 5 years at 14%. Our experience in that time from 2019 to 2023, we delivered 1,000 single fraction treatments and approximately 1,000 multi-fraction treatments at Peter Mac, predominantly for oligometastatic disease in the single fraction cohorts. That's 50% of our treatments. And I think we're not going to change from that from our current pathway forward. We're finding this a very useful treatment strategy, particularly for patients who are traveling some distance to get to the institution. And with that, I'd like to thank you for your attention and thank you again for the organising groups from ESTRO and EORTC for the invitation to speak. Good night.
Well, good night, good evening, good morning. Many thanks, Shankar, for delivering us this perfect talk. And I would even say that the last slide could be the ideal summary of this session. Shankar is giving a wonderful presentation and convincing us that there's value for even more patients being treated with single fraction SBRT. And he showed us the data from his home institution where 50% of the patients are being treated with single fraction. But that also means that 50% of the patients are not being treated with single fraction. They are treated with 2, 3, 4, and 5 fractions. And the same we are seeing in the chat here. We're seeing a lively discussion how to design the next generation of clinical trials. Is it disease specific? Can we group all breast cancer patients into one cohort, or do we need to separate? Most likely we will do clinical trials, registries which are more disease agnostic, which are having broader inclusion criteria, and we will have in parallel clinical trials very informative, focusing on specific subsets. That's what we're trying to move forward within the ESTRO and EORTC OligoCare consortium, to deliver evidence based on large number of patients being treated within our day-to-day clinical practice to generate hypotheses for the next generation of clinical trials, and also to develop this registry trial into a randomized setting using the TWIX concept. Are there any burning questions before we wrap up and close the session almost perfectly on time? If not, I would like to express my deep thanks to all speakers who have given wonderful presentations, sharing their latest clinical trial results, dedicating their time. Many thanks also to ESTRO and EORTC staff for preparing and supporting us for this symposium. And last but not least, many thanks for all of you joining us. It's late in the evening already, and we had more than 200 participants. Many thanks for staying with us, for supporting our research in the field of oligometastatic disease. Wish to see every one of you in the ESTRO meeting in Glasgow, and hope to see you and greet there in person. Many thanks and enjoy the evening. Bye-bye.